Bismillahirrahmanirrahim. Today we'll be discussing residual and relapsing CTEV, and along with it I will try to clarify different definitions used for the Clubfoot. Today we will be discussing residual and relapsing CTEV. It means by definition any deformity occurring after commencement of foot ankle orthosis, that is, you have completed the casting process, you have witnessed that the foot has been corrected, and then you apply a corrective cast, DB shoes or AFOs, and then after some time you notice a recurrence of a deformity. Then it is called as a residual relapsing deformity. The foot is considered resistant when the deformity shows no evidence of improvement after 3 months of adequate conservative treatment. We mentioned a little bit of this definition in the last lecture also, that when you find any deformity resistant not improving after 2 casting, then you should move to the next step. And it should be remembered that when you talk about the relapsing or residual or resistant clubfoot, it is not full-fledged deformity that you are encountered with. So it is always some part of the deformity that is resistant, and we will see which part is most relapsing and most resistant to the treatment. So Ponseti casting effectively corrects about 95% of the cases. But we also face 5%, which is also a large number. Correction is achieved in majority of cases in 4 to 6 weeks. Last 2 casts should be applied while the foot held in over-corrected position. And in 70% of cases, minimally invasive surgical procedures like percutaneous tendinochirus lengthening is required. While in 3 to 5% of cases, they may require extensive soft tissue release. They are not a short procedure, but you will have to do the full-fledged operative correction of the foot. The feet corrected by Ponseti casting. Now, this should be your preference. So, in the last lecture, we set the objective of the treatment. What was the objective of treatment? There were 3 objectives: plantigrade, painless, flexible. So these three things should be observed with a normal gait pattern. So that objective is best achieved when the foot is corrected by Ponseti casting. Now this has got the 2 aspects. One aspect is the feet which are corrected by Ponseti casting are probably of a lesser severity of pathology. That is why they show good results. And when we operate, obviously these feet are more resistant, more rigid feet, which are of different pathologies and may result in a poor function. So you cannot compare these 2 approaches. We are the practitioner of both approaches. We do the Ponseti casting and we do the surgery. But the important thing to learn is you cannot say that the Ponseti results are very good, they achieve better results, why to go for the surgery? This is not a right statement, because Ponseti is successful in cases where the deformity is less severe, and we have to subject the surgical approach for the feet which are not responsive to the Ponseti casting. So these pathologies are of more severe form, so the results obviously will be not as good as they are in Ponseti. So you should not be comparing these two area of treatment because of the 2 different circumstances. You cannot compare onion to the apples. So remember that each foot is different. And for the comparison purposes, you should be very meticulous to compare the alike feet together, not one feet of other character and another the totally different characters. So we'll be noticing these changes in today's lecture. So in some feet, this ideal functional outcome becomes unrealistic because of the deformity of ankle. Stiff, severe, small size CTEV tends to relapse more. Now these are the different examples where we need to have surgery. So stiff, severe, small size CTEV tends to relapse more, and these kind of feet are often referred to as atypical congenital talipes equinovarus. There is a variety within the congenital talipes equinovarus with the idiopathic form. You will see a feet very small size where the cast is really loose, and the child comes again and again with the feet out of the cast. So these feet are usually called as atypical, and we'll see the example of this atypical congenital talipes equinovarus. And other feet, those are non-responsive to the concentric casting, may be from the syndromic and neurogenic feet. They are more prone to relapse and they are more difficult to treat. And the post-relapses develop gradually and may be difficult to recognize early. The other problem is that they are very difficult to recognize. So they relapse slowly. So to this you should be knowing that most of the relapses occur within 1 year. Why? We have noticed that the clubfoot deformity is a variety from developmental anomalies. And what we mean by developmental anomaly is that the growth of the bone and growth of some part of the soft tissues, tendon and muscles are not synchronized. Bone growth is more than the tendon and muscle growth, and if you don't follow them, then deformity will reoccur. So most of the growth will take place within 1 year. So the most chances of relapse and recurrence is within 1 year of the treatment, and then it decreases with the advancing age up to 3 years. But to be safe, the feet should be followed up for 5 years. So what should be the protocol then? The increased risk is within 1 year, so you will be having a very close follow-up within 1 year of the treatment. Then you will increase the interval in between the examination for the rest of the years. And a little more relaxed attitude up to the 3 years, maybe 3 monthly follow-up, and then after the age of 3 years you can shift it to the 6-month follow-up examination. But you should be following your patient up to the 5 years of age, and you should educate the parents of the patient that the patient needs to be examined again and again for up to 5 years, and you cannot declare that the foot is treated before you see your patient that the 5 years have gone uneventfully. So not all components of CTEV tends to relapse to the same degree. If there is a relapse of 2-3 component, one is the severe one, other is the minor one. So we will see in the examples in the later part of the lecture. Earlier the deformity is supple. The second character is earlier you detect, it is supple. It is more easy to counter. But if you keep on neglecting, then it will become rigid and will need more extensive procedures for the correction of those deformities. So this tells you a very psyche of the surgeons, that the surgeons really don't try to accept that the deformity is recurring before the parents. They think that it is their mistake and it should be hidden. No, this is not their mistake. This is the pathology that you are dealing with. And if you have adequately educated the parents, then it is not difficult to admit that now this is a time to intervene again. Okay? So it is the duty of a surgeon, duty of a treating physician to educate the patient that once the feet are corrected, it is not guaranteed that the deformity will not recur. It is not guaranteed the patient will not have surgery. So education is the most important part for the parents and for the surgeons and treating physician as well. So the lesson is, so you should intervene earlier. What is the mistake that I'm looking in my daily practice? That the doctors, first of all, they lock themselves that we are going to correct this deformity in 6 casts because they have learned this in Ponseti workshops. So you lock yourself. मैं इसको कहता हूँ आप बंद गली में दाखिल हो गए जहाँ से आपको निकलना मुश्किल हो जाएगा. तो प्रैक्टिस के अंदर बंद गली में आपने दाखिल नहीं होना. ठीक है. Keep your ways open for you and for the patients. So don't apply AFOs and DB shoes once you see that the feet are not corrected. If they are under corrected and you just due to your commitment, you shift to the next level of treatment, next level of management. So you trap yourself in a situation where the relapse will definitely happen. So you keep on applying the cast or keep on changing the treatment unless the foot is correct, is fully corrected. You should not apply the orthosis, DB shoes, and you will see in your practice these mistakes. So once you achieve full correction, what do you mean by correction? It is fully supple, flexible, it is plantar grade, and it is painless with a normal gait. So you can't see a gait within 1 year of life, but afterwards you can see a changing in gait. So Clubfoot is a developmental anomaly, but the things that I was explaining just now. It starts in the third month in the intrauterine life and persists up to 5 years of age. So this is the time where you see the relapses. It is due to dysfunction of muscle balance and an excess of collagen synthesis with retracting fibrosis in the posterior and medial part of the leg and foot. The speed of growth of foot decreases after 1 year of life and diminishes greatly after 5 years of age. So these are some of the classification. Once you start treatment, you need to have some standardization for the treatment purpose because you cannot compare the feet. You will find all these things in the best form that you want. So just concentrate. So grade 1A. So we have the Bhaskar and Piyush Patani have classified these kind of food. So another lesson is that don't follow Pirani classification in each and every case. These are meant for the plan of Ponseti casting. If there is no Ponseti casting in your plan, then the classification will change. Right? So these are the classifications. So it published in Indian Journal of Orthopedics in 2013. Grade 1, decrease in ankle. So you will be noticing that it is the variables are ankle, variable are the supination, pronation, reduction, abduction. So according to these variations, decrease in ankle dorsiflexion from 15 degree to neutral with passive stretch and knee extension is grade 1. In grade 1B, dynamic supination or reduction on walking. So you see the dynamic change. The gait is not normal, otherwise feet are normal. This is 1B. Then grade 2A, fixed ankle equinus of any degree. Grade 2B, fixed adduction which is not correctable by passive abduction of the foot, that the varus is fixed. And grade 3 is combination of fixed hind foot equinus plus forefoot adduction and cavus or complete rigid equinovarus foot. So these are the classification by Bhaskar and Piyush Patani. Patani. So this is classification presented by me, and published in Journal of Institute of Medicine in Nepal in August to December 2016. And it says, first part, classify it into idiopathic, into syndromic and neurogenic, then individualize different deformities and classify them. Dorsolateral hump, 0, not palpable, 1, when palpable but reducible, and sec2, it is not irreducible. Then midfoot crease, it is not present, half crease and full crease. So according to the severity of the deformity. Then equinus is flexible, not present. Then it is rigid without posterior crease, and then rigid with posterior crease. Then there are some individual characters. Thin skin, we operated on the last list. Thin skin and then short first ray. Then they exist or they don't exist. So these are the parameters on which and this classification is specifically applied for the decision making of the surgical procedure that you will proceed with. Then correction of CTEV, adequate concentric casting achieving over-correction of abduction, then maintenance of correction and detection of early response with immediate remedy. So these are the examples. This is one example, a patient with a neurogenic CTEV with myelomeningocele. You will see the equinus and adductus. Then metatarsus adductus, looking at on the right side, left side of your screen, but the patient is having right foot. Then again arthrobrachosis. Other deformities are also present, and we saw the case we operated yesterday. Then this is the atypical foot. Remember this shape. Empty heel, small size, the full midfoot crease, and small thumb, a big toe. These are and it is very chubby-like, fatty-like feet, and they are very difficult to hold in the cast. So this is the way that you will. This is the case I operated yesterday. And I have applied this child concentric casting. He was very well corrected at the age of about 3 months. He was given cast, but it is a evil story that after some times parents won't worry to follow the cast regime and even follow your doctors. So they visited me in about 1 year and 7 months only once, and they came again when the child had developed the deformity at the age of 2 years. So you can see on the right side there is a 135 degree of angle in. This is the right side with the half midfoot crease, metatarsus adductus. It is not varus, it is metatarsus adductus. So this was the way the patient was walking, toe walking. Heel was raised on the right side, and now you can see all three pictures. On front there is no varus, equinus is rigid, and you see the sole, it is adductus. So the recurrence of the deformity is in adductus and equinus. And equinus is the most common finding that you will see in a relapsed feet and resistant feet. This is after correction. We did the posterior release. You can see the small marking of scar, stitched part here. So what he required is the posterior release according to the deformity that we saw. And this is the amount of correction that you can see operatively. ठीक है, इसके आगे इंशाल्लाह
what about the adductus, metatarsus adductus?
वो वैसे
It was corrected with that posteriorly.
उसमें ये कि हमने वो tibialis posterior भी उसी अप्रोच से और flexor hallucis भी उसी अप्रोच से जब हम करते हैं तो वो adductus को करेक्ट करते हैं।
स्टैंडर्ड भी चाहिए होगा इसमें?
इसमें नहीं मैंने की स्टाइल
There was no tightening of the plantar fascia.
because once I corrected the flexor hallucis longus, the cavus was corrected and the adductus was corrected, so there was no further procedure. The important thing is that even during surgery, you keep on noticing the amount of correction that you are achieving. Suppose I started with the posterior release, and once I really I do the Z-plaster of the tendon Achilles and the foot is corrected fully, so I won't proceed further. If it does not, then I'll go deeper and deeper. So this is the principle, that you see the amount of correction that you're getting per operatively. This is what we call as a la carte approach. So always be prepared that you are going to do a minimal surgery which is required. Don't fix yourself that I am going to these 16 procedure of turbo release. Have you counted them? What are the different procedures in turbo release? These are 16. Turbo, postomedial release. So you should not fix yourself to the 16 procedure that you are committed with. So do whatever is required, and you are free to use this choice even during the surgery on the operating table. Yeah.